Central lines, if you noticed way back in the beginning in the state protocol, it said may access central lines with the approval of the medical director. CREMCA has approved us to access central lines. So this is going to be the teaching on central line access.
Does that carry into the EMS world as well? Someone has something going on a one call?
This is officially within the state protocol for the inter-facility transport. Okay. Yeah. Now that you have this training, you'll probably feel more comfortable touching a central line. I would say that on the pre-hospital side, I would call med control for an order if I was going to do that. But it's not that big a deal. Thanks, Dave. All right. So a PICC line is a peripherally inserted central line catheter. That means that it's going to start in one of the periphery, like the arm or the leg, usually the arm, and it's going to go into the chest, and it's going to terminate in the superior vena cava, just above the right atrium. All right? So that means there's a plastic tube that starts out there in the arm, and the end of that plastic tube is dangling just above the heart. The problem with that is any bacteria that get into that plastic tube go right into the middle of the chest. So if you get an infected peripheral IV, we pull it out, we give you some Keflex or whatever, life is fine, right? If you get an infected central line, first of all, your blood is washing across this at a very high rate of speed, so you're probably going to wind up with bacteria throughout your entire bloodstream, bacteremia, sepsis. And then the next problem is, how do we treat you, right? Because now you maybe have accumulations of bacteria right in the middle of your chest in a place where we really don't want you to have bacteria, okay? So the biggest complication with central lines, hands down, is infection. So the thing to do about that is hand hygiene, all right? So hand hygiene is the #1 way to reduce hospital-acquired infections in general, and that's true for central lines as well. So the first, middle, and last thing for you to take away from central line discussion is do your hand hygiene and do your aseptic technique and be religious about it. Take the time. I know in EMS land we scrub with alcohol and then we stick, but it's really important to take those extra 30 seconds and let things dry, make sure they're clean. Clean yourself, clean your hands, change your gloves, because a central line infection is no joke for you or the patient. So peripheral, frequently a PICC has 2 ports, and 2 ports are nice because there's 2 spots to run incompatible medications like Zosyn and whatever. You get it. It's good for caustic agents like vancomycin. Remember I said vanco has a pH of 2.5, so I don't want that running through a knuckle vein. I'd much rather have that run through a big vessel in the chest where it's quickly diluted by the rest of the blood volume, okay? So it can also be used to draw blood, which is nice. If you have a sick patient and they're getting poked a lot, maybe they have crummy veins, you can use a PICC line to draw their blood in the morning, and now they don't have to get poked. Super. Questions about PICCs? Pretty simple. This is a triple lumen central line. There's 2 locations that are the most common. You'll either see it in the internal jugular, about the middle of the neck between the jaw and the clavicle, or you'll see it in the subclavian. And it can be on either the right or the left of either the neck or the chest. Triple lumen just refers to the fact that there's 3 ports. There are 2-port and there are single-port central lines. But triple lumen is the most common. These are pictures of central lines in the neck, and then that happens to be in the groin as well. Yes, Jeff?
Does it matter color, which one you access, whether it's the middle,
doesn't
distal?
Matter. No, doesn't matter. No, it's all the same.
What about the okay?
What about what?
Well, the red one, you obviously don't want to access that, right?
If it is a if it's a dialysis catheter, we don't want to access that. If it's an arterial line, we don't want to access that.
Right.
Yeah.
It's usually arterial.
Red can be arterial, but not always. Yeah. Typically, there's a blue, a white, and I forget the other color. Brown. Blue, white, brown. Yeah. For central lines. And you can see them in the groin as well. If they're in the groin, they're a temporary line. We typically take them out in 24 hours because the groin is such a dirty location and the incidence of infection is so much higher.
Can you just go back one slide?
Yeah. Yep. All right, so things to know about a fresh central line. You want to know if the line has been confirmed by X-ray. So we get an X-ray after the placement of lines because we want to know that it went in the correct spot. And we can see the tip of the line hanging hopefully right above the heart. And is there blood return, right? So just like an IV, if you can draw blood out of it, we know that it's probably in the vessel. When they're placing a central line, they put a needle in there and then they fish a wire down there and then they fish the catheter. Hopefully the wire fishes smoothly and everything's good. It is possible to get outside of the vessel and then fish the wire in the line into not the vessel, right? So that would be a situation where you didn't get good blood return. Does it flush easily? Now, flushability doesn't guarantee safety, right? If the line is like hanging in the chest, maybe in the lung or something, it's still going to flush really easily for a while, right? But if it flushes well and it returns blood, these are reassuring things for a fresh line. But you do want to ask the question, is the line approved for use? Because typically, immediately after placement, they'll get an X-ray, and then the provider will say the line is approved for use, or you're okay to access. Okay. Complications for a central line are pneumothorax. That's especially true in the subclavian location. If you angle the needle a little too low, you're going to get into the pleural space, and then boop. Bleeding, because anytime you're touching a big vessel, you have the potential for bleeding. VTAC, and that's associated with a line that's placed a little too deep. We do it by height, and then there's kind of a calculation that they do for how much catheter to insert. But if you insert a little too much catheter, it'll go from hanging in the superior vena cava just above the right atrium. It'll go into the right atrium and into the right ventricle. And if it goes into the right ventricle, when you touch the inside of that, it really irritates the heart. You'll get frequent PVCs and sometimes continuous VTAC. So, yeah.
With the VTAC, is the threat of that more when it's being inserted, or can it show up later?
It can show up later with a malpositioned line.
Okay.
I actually had a paramedic friend who got meningitis, and she got I think it was a central line actually, but she went into VTAC in the middle of the night, and it was because the line was too deep. So they can migrate, or they can just be put in a little too deep anyway. But if you have a patient with a fresh central line and you've got VTAC, that would be one thing to think about. Yeah. And then of course there's wrong placement; it just goes in the wrong spot.
Marcus, if you suspected that was it, would you try to treat the VTAC?
You could try treating the VTAC, but in my list of things, I'd also call med control and think about pulling the line out. Yeah. Which, is not an insignificant intervention. Might not be the first thing I did, but it's on the list.
They do that under fluoroscopy or something, correct or not really?
All we do is an ultrasound at the bedside.
Okay.
Yeah.
So to pull it, if somebody else has put it in, you have no idea where it is or anything like that. Is that a threat in any way to pull that?
No, DCing lines is pretty straightforward. There's always the risk of bleeding anytime we DC a line. But we DC lines regularly, and the incidence of complications is super low. I'd say the biggest complication is now you don't have a line, which sucks. I wouldn't do that without talking to a doc. But if you have persistent ectopy,
They're stitched in there.
they are stitched, yeah. Most commonly, this is going to be the line got put in too deep in the first place. This is rare. It's in the body of things to know. Yeah. What's that?
I just don't want to pull a chunk of the heart out.
No.
That would really bother me.
That would bother me too.
Indiana Jones.
I'm going to cover DC on a line just in case it gets dislodged, but they come out
But
easy.
that is something we could do if that's like what it is. I guess that's what he's trying to ask.
Yeah, I think with
them
with
and
med control
transfer.
first,
Yeah.
with them saying, pull it back, that would be a reasonable thing to think about.
And you're just saying to pull it back a couple centimeters?
Unfortunately, because of all the risks to infection, if it has to come back, it has to come out.
All the way.
You can't have it. Now, providers will occasionally, they'll put the dressing on, they'll get the X-ray, and they'll say, "Ooh, it looks a little deep. I'm going to pull it back." So they'll undress it, they'll pull it back in the commercial holding device, and then they'll redress it all under sterile technique. We don't have that luxury in the back of the ambulance, so that's an exceedingly rare thing to have happen. But as illustrated with my friend, it can occur. So I just want you to be aware of it, put it in the back of your mind as a differential for a reason somebody's having all of this ventricular ectopy, And then if they're having a bunch of ventricular ectopy, with consultation with medical control, you would think about maybe pulling the line. It's just something to know. So, if that is what's driving your ventricular ectopy, standard interventions, amiodarone, whatever, may not be effective.
No, but just, if you do pull it, does pulling it have the same effect with irritation? Like,
No,
should
as soon
you-
as it's out, you're done.
Okay,
In fact, one of the ways that we confirm that the wire is where we think it is sometimes the physician will intentionally put the wire deep and cause a little bit of PVCs. And one of the nurse's jobs during placement of a line is, as they're starting to fish the line,
Okay, watch.
you'll say sinus rhythm, which means I'm watching. And then if they get a bunch of ectopy, the doc will pull back because it means they've gone too far. So, but I have seen docs who had kind of a, they weren't 100% certain on the insertion, where they'll intentionally drop the wire a little further. And as soon as the wire comes back, the ectopy is resolved. So, PIC line, that's a picture of a PIC. That's a real picture of a PIC. So Bob, you were talking about colors. Unfortunately, colors do not necessarily equate to arterial. So this PIC line is a good example where it has a red hub, and that doesn't mean that it's arterial.
I guess you should assume if it's a PIC it's gonna be in the vein, not in the artery, so it really shouldn't be a.
Yeah.
I had one of those once, and I wasn't sure about that one, if that was like if something happened, if that had been like a return or something.
Right. And Maherkers or dialysis catheters do have red and blue ports, and you definitely don't want to access the red one. So one of the questions when I teach this is to just ask what the line is, right? So I see this all the time. People will say, oh, they had a Maherker in their chest. Well, first of all, Maherker is a brand name like Xerox, okay? So if it's not the brand Xerox, then that's inaccurate. And then second, just looking at the chest, it's extremely difficult even for nurses, especially like with differences in brands and stuff, to necessarily know this is a dialysis catheter versus a central line versus something else. So just going off of colors of ports will not be sufficient for you. You do just have to ask the question. And they'll tell you they have a triple lumen central line, subclavian left side. Great, now I know, all right? So that's a picture of a PIC. PIC complications, dislodgement, bleeding, infection, VTAC. So dislodgement, a PIC is basically like a long IV. It just happens to go across to the center, to the middle. If you read the books on DCing them, under idealized conditions, you would remove the dressing, clean around it, and then remove it. And when you're removing it, you're just using one long, smooth motion. They're about this long, so you're just going to pull one smooth motion for a long time, and then apply pressure at the insertion site. And that's all. Some of the old teaching was to have the person take a deep breath and hold it while you were pulling the central line. And that has really been proven not to make any difference. But if it makes you feel better, you can tell the patient to take a deep breath, and that's to reduce the incidence of pneumothorax, although it's now kind of been proven not to be as big of a deal. The reason I'm talking to you about DC and central lines, because you're probably not going to DC it for VTAC, right? But let's say the patient, is confused or something, reaches over and pulls it halfway out. Well, remember what we said about infection. We can't just leave it in there. So at that point, you're going to DC it. And it's just one smooth motion and put a piece of gauze over it. Anybody who's been an ICU nurse for a while has inadvertently DC'd a central line. They get ripped out in the bed rail. They get ripped out in the CT scan, just like IVs. It's an unfortunate phone call to have to make, but it's not the end of the world. That's how to DC them if they get dislodged and you need to complete the halfway removal. So a port or a portacath is usually in the left anterior chest. Sometimes it's in the right, usually in the left. There are two parts. There's the port, which is under the skin and accepts the needle. And then there's a little tube that goes down to the superior vena cava. And it's great for chemotherapy or intermittent infusions. One of the benefits is there's not constantly something outside the skin to collect bacteria and get those bacteria pushed into the central circulation. So ports are used for chemo patients a lot. Complications are infection, because you still have a foreign body that's sitting in the chest, and if there is an infection, it's a big deal. And bacteria love to adhere to things that are not human, because they can get a foothold and someplace to attach and live their dirty little lives. So infection and pneumothorax during access are the two concerns. All right, so this is a picture of a port On the left-hand side, you can kind of see the cartoon image, and then on the right, you can see it in an actual patient. And if you really pay attention, you can actually see the tube just underneath the skin, ascending from the port and going up into the neck. So the needle goes into that little purple part at the bottom. That's a picture of it being accessed, and that's the specific needle that needs to be used to access that port. You don't access a port with like a standard angiocath or something like that. If you have occasion to interact with a patient who's already had that accessed, be aware that if you have occasion to deseed the needle, which is not a big deal, they just put another needle in when they get to the hospital. Let's say it gets dislodged. These things are notorious for sticking healthcare providers because there's a little piece of plastic that's supposed to slide down and stabilize. And when providers pull them out, they stick themselves. So just be really, really careful. Use one smooth motion, make sure you get it all the way out, and a lot of times there's a hot needle hanging out the end of it. The way I can liken this or compare this for you is if you've ever DC'd an IO, you pull out and you got a big hot needle aiming at you. Just be aware there's a high incidence of needle stick with these. Hopefully, once they've accessed it, you just leave it in. That's a sterile dressing over the top. The beauty of this is it becomes a central line, right? So that means that you can use high-dose Levophed, vancomycin, you can push that dextrose. Life is good, all right? So it's nice to have a central line. A tunneled catheter is typically used for dialysis and is going to have red and blue ports. It's usually in the neck or the anterior chest. This is a picture of a tunneled catheter, and the reason it's got the red and the blue is for the artery and the vein. There's one where the blood's being drawn off and the other one where they're pushing the blood back in. That's a picture of a dialysis catheter. You can see how similar that looks compared to a central line. You guys okay? You can see how similar that looks to some of the other pictures, and these happen to be dialysis catheters. A midline catheter is just a long IV. The midline is defined by not crossing the axilla, so it's just in the arm. If you see something labeled midline, feel free to use it. All it is a fancy IV. We are using these at both community and St. Pat's. You will encounter patients in the community that have them, even on your pre-hospital calls. Feel free to access them. They're no different than a regular IV. Okay, things to know about all central lines. Access is for emergency only in the pre-hospital setting. In the interfacility transport, you can consider yourselves trained on this if you can remember that the most important thing is asepsis and hand hygiene. Okay, that's the big concern. You want to scrub the hub and let it dry for 30 seconds on the clock. I know that, again, in EMS land, we think we're in a hurry, but you being in a hurry and accessing a line and getting it contaminated is going to affect that patient for a long time after you leave. So make sure to scrub, and you want to scrub for the full 30 seconds and then let it dry for 30 seconds. Remembering that the alcohol drying is the part where the bacteria are actually being killed. So scrubbing and then accessing while the port is still wet is almost like you didn't do anything at all. So really important to let it dry. And then it's absolutely essential that you've cleaned your hands first. If you're accessing a line that is like been placed and not currently infusing, you want to draw back 20 mils of blood and waste it. Some of these lines are packed with porcine heparin. If it won't draw or you don't have time, it's not the end of the world. The porcine heparin is extremely low, diluted heparin, it's a small amount. But we try not to administer heparin to patients inadvertently, so drawing a waste out of it. And that also lets you confirm that there's blood drawing back, which is reassuring as far as confirming that the line is in the correct spot. If you're removing, the book says to take a deep breath and pull slow with steady pressure. And an occlusive dressing and holding pressure for 10 minutes afterwards. Subclavians, you really can't hold pressure. You can hold at the insertion site, but where it actually went into the vessel is probably under the clavicle. So those are a little harder to hold pressure on, but you do what you can. Questions? All right, so scenario, 75-year-old male in an outside hospital with low blood pressure and shortness of breath. Pulse rate's 105, he's in AFib, 84 over 58. Respiratories are 14, 90% on 2 liters O2. So he's diagnosed with new heart failure, acute on chronic renal failure. Interventions, they gave Lasix, which resulted in 750 of urine out, and then he had an even lower blood pressure. Not uncommon for Lasix to cause lower blood pressures. So they added 5 mics of dopamine to the central line placed in the right groin. Questions? Okay. So the scenario, during transport, the blood pressure is now 70/40, so you titrate the dopamine up to 15, and there's no improvement in the blood pressure. It's now 68/40. The patient is complaining of stinging and burning in both feet, and the feet are cold and pale. What do you think?
He's not refusing.
Yep, not moving blood around, pressure sucks.
So we might be too high on the dopamine.
Maybe the dopamine's inappropriate, yeah. Because you went from 5 to 15 and your pressure actually went down. That's strange.
I'd say.
Better make a phone call.
There's no fluid,
Yeah,
that's-
definitely. Jeff's big on phone calls, and I am too. Yeah,
Yeah.
make a phone call. All right.
Possibly what we're doing.
All right. So this patient really happened. This really happened, by the way.
Hold on, I want to look at this yet. So, hold on. What was the diagnosis? I've already forgotten.
Renal failure.
Renal failure
Okay.
and what? Some heart failure, right? Yeah.
So then, all right, so they gave him, they were diuresing him, and then his stats were crap on a couple liters.
Yep.
Okay.
My guess is they infiltrated that central line somewhere and he's bleeding out.
So if you switched the dopamine from the central line to back to a peripheral, the patient stabilized.
Yeah, that's bleeding.
If you gave 1 liter of fluid, the BP rose, and then the patient developed shortness of breath and required 15 liters oxygen and got volume overloaded, okay? Because he needed more dopamine and he wasn't getting it. If you did nothing, the patient had acute renal failure and now lives on dialysis from a medical error. The error was arterial placement of a central line, okay? This does happen. You know, we use ultrasound to try to make sure we're aiming at the correct target. That's new, by the way, it wasn't always done. And some providers are more expert at using ultrasound than others, but ultimately you're aiming at vessels with a needle. And especially in the groin, the artery lies right next to the vein. So it wouldn't take much, a little change in needle position, and suddenly you've threaded that central line. What's that going to look like on x-ray? It looks like the catheter is hanging out, you know, in the vena cava, but what's the difference between that and the aorta? Not a lot on x-ray. Okay, so that would be a subtle thing that would be easy to miss. Hopefully you'd notice the bright red pulsatile blood out the IV, right, or out the needle. But, you know, if the blood pressure is really low, sometimes an artery doesn't look so great either, right? So I have seen patients that had accidental arterial placements of central lines. And, you know, if you think about it, you're infusing all that dopamine, but it's going into an artery, right? So the artery then distributes, and where's all the concentration of drug? It goes down the aorta and into the feet, and it's causing some vasoconstriction. So that's why you're not getting a result from the dopamine. And that's why the feet now have pallor and cool, you know, because the circulation sucks. Plus their blood pressure sucked anyway.
So if you use that call, would the doctors say remove that line, or would they?
No.
Just
If
stop.
we put a line into an artery inadvertently, it has to be removed in interventional radiology by a super specialist. So absolutely, I'm not going to touch that.
Lock it off and just leave it alone.
Yeah, just lock it and leave it alone. You know, hopefully you would figure this out, but it does happen, right? And so I'm encouraging you to think about central lines. I don't want you to think that they're just like, you know, beyond question, because even central lines can go bad. So did you call
Did he
ahead?
have a peripheral line? Did we know that?
What's that?
Did he have a peripheral line to begin with?
Usually they'll have a peripheral before they get a central, but I guess I didn't tell you they had a peripheral. But
Yeah.
so I guess
My
my
assumption would be if he didn't have a peripheral line, he's got pressures of that, it's gonna be tough. It's gonna be a tough road to hoe to get one.
yeah, you might be looking at IO for sure. Yeah. You know, this is just like your IV. You give a dose of something and it doesn't seem to have gotten to the patient. You start wondering, you know, like, is my IV still working? You know. So arterial placement is thankfully exceedingly rare because we have all these safety checks, but it does happen. So just something to think about. And that did happen at an outside hospital. So I'm not just completely making this stuff up like it never could have occurred. All right, so that's central lines.